Methadone is an essential drug for the relief of intractable, severe chronic pain when nothing else works. It became an important drug in treating chronic pain, especially neuropathic pain, in my hospice and palliative care practice in 2000 as a result of, one, the EPIC program, Education in Palliative End-of-Life Care, where I was taught by experts for the first time in my 42 years of practice as an internist how to properly manage severe chronic pain. Then, 2 articles by Dr. Daniel Brookhoff in the journal Hospital Practice in 2000, Chronic Pain, a Disease, and The Case for Opioids. These gave me a new pathway to follow to help my palliative and hospice patients who were suffering from chronic pain. Methadone was the 10th most widely used drug in end-of-life care worldwide in 2000, with no stigma except in the United States. Here there seemed to be overemphasis of the side effects and potential dangers of methadone without much emphasis on its benefits. In continuous medical education programs by for-profit medical education communication companies, or MEC, the drug industry has had a near monopoly control of the MEC program, raising questions of bias in their presentations. There has been slow but steady evidence of methadone's benefit in relieving severe pain unresponsive to other opioids. In my practice, 3 of every 4 of those pain patients had good or excellent relief. There have been national efforts to limit opioid prescribing for chronic pain because of recent increases in morbidity and mortality related to the non-medical prescription use of opioids. A nationwide drive to limit or discourage the prescribing of opioids by primary and specialist physicians is appropriate and is being implemented. In studying adult patients aged 18 to 64 from 2000 to 2013, while the prevalence of non-medical opioid decreased 1%, mortality and morbidity increased. This is an article by Dr. Han and colleagues in JAMA in 2015. The article by Han et al. Is from the Substance Abuse and Mental Services Administration, the National Institute on Drug Abuse, the National Institutes of Health, and the Food and Drug Administration. It's important to realize that the population that these agencies are concerned with are in many ways different from normal pain patients who are not addicts, whose pain is real, and who deserve care by a dedicated, empathic physician who will follow appropriate guidelines. Unless there is recognition of policymakers of this non-addict pain population, there is a risk of throwing the baby out with the bathwater. For that non-addict population, access to patients trained in chronic pain management is essential, who may utilize the full array of opioids, non-opioids, and adjuvants, including the NMDA receptors, blockers, levodopa, methadone, and ketamine. Let me give you some case examples of methadone efficacy in the treatment of chronic pain. This first case of postoperative pain, Tom, age 75 years, had an abdominoperineal resection for anal cancer in April after radiation chemotherapy. Constant postoperative lancinating and burning pain of scrotum, inner thighs, and perineum was unrelieved by hydrocodone prescribed by surgeon, oncologist, and urologist. He was unable to sleep well, was unable to sit down due to unrelieved pain. Depressed and exhausted, after 3 months, he attempted suicide in July. A stay in a psychiatric hospital and antidepressants helped, but the pain persisted. In October, a wound specialist nurse arranged for a palliative care consultation. After a thorough history and examination, the patient reluctantly agreed to a trial with low-dose methadone. As a therapeutic trial, 1 5-milligram methadone tablet orally at bedtime was prescribed. I asked him to report to me the next morning, and Tom reported that he slept soundly that night, pain-free for the first time since his operation. A dose of 2.5 milligrams every 12 hours controlled his sacral neuropathic pain for the next 18 months. The neuropathy slowly decreased thereafter. Another case, post-traumatic low back pain. George, age 56 years, was referred for pain management by his pain anesthesiologist after poor relief with interventional pain therapy and hydrocodone. As a young man, he had multiple injuries as a rodeo rider. While in Vietnam, he had a back injury, underwent a lumbar fusion, and was treated for PTSD after discharge. Severe chronic pain was present for over 5 years. George became depressed and considered suicide, which required treatment at a VA hospital. His pain persisted, limiting his function. Oxycodone and sublingual fentanyl were ineffective and expensive. After palliative care evaluation, George was converted to methadone, 5 milligrams orally every 8 hours. After 3 days, his pain score dropped from 7 and 8 on a 10-point scale, where 0 is no pain and 10 is the worst imaginable pain. It dropped to 0 to 3 on that scale, and he's remained on oral methadone, 10 milligrams every 8 hours, and is much more stable physically and emotionally. Another case, lung cancer with spread to pleura and ribs. 60-year-old Pat, seen in an oncology clinic 1 month after diagnosis. His pain is at a 7, sharp, aching with activity and with cough. Lortab, 10 milligrams every 4 to 6 hours as needed, had not helped during the past 2 weeks. He was rotated to Percocet or oxycodone. 5 to 10 milligrams of Percocet every 4 hours around the clock helps after 3 days. He was taking 8 tablets of 40 milligrams in 24 hours. When the pain persisted, he was converted to OxyContin, 20 milligrams every 12 hours, with Percocet 5 milligrams every 4 hours as needed for breakthrough pain. Despite aggressive treatment, he develops metastases to liver and spine. Pain becomes severe with somatic, visceral, and neuropathic elements. The OxyContin was increased stepwise to 80 milligrams every 8 hours. No relief. Dilaudid begun by PCA pump, and then a dilaudid intrathecal pump is helpful until he becomes septic. The intrathecal pump is removed and the PCA pump is resumed. It was not controlling his pain, a score of 8 to 10, and he was on 2 milligrams an hour plus 20 milligrams demand for a total of 68 milligrams in 24 hours of intravenous Dilaudid. He was converted first to morphine, oral equivalent, in 24 hours, then to methadone. He was converted to methadone. The conversion ratio is 20 to 1. So the methadone dose was 68 milligrams in 24 hours. And he was dosed 20 milligrams every 8 hours, and parenterally it could be half that dose. And for breakthrough pain, 5 milligrams oral methadone every 4 hours as needed, with reassessment often to adjust the dose up or down. And his pain was controlled adequately at a score of 4 to 5 until death. Why is methadone so effective? First, it's a mu receptor agonist, like morphine and the other conventional opioids. It is also an NMDA receptor blocker, similar to levofinol and ketamine. So it has a double barrel effect on chronic pain. In addition, it does affect norepinephrine and serotonin reuptake inhibitor. It is an inhibitor like the mild antidepressants. It has a long half-life, which allows 6, 8, or 12-hour dosing. It is less constipating, less nausea and vomiting. Its metabolism is fecal and hepatic, and it has no effect on renal function. My nurses in hospice, after working with me for some time, preferred methadone, low-dose methadone for hospice patients with chronic pain. They preferred it because it worked faster, patients were less constipated, they had less nausea and vomiting, and control of pain was considerably faster than with conventional opioid. What about their side effects, which have been so emphasized in the literature? The electrocardiographic QTc prolongation. We tend to avoid methadone in chronic heart disease or in patients with known long QTc. We order EKG as a precaution in chronic pain patients, except for most hospice patients. And if we are concerned about a QTc prolongation, we switch to levofinol. What about CYP 450 side effects? Adjuvants are seldom needed when methadone is effective. So the fewer drugs that patients are taking, the less we have to worry about with those side effects. We know which drugs increase or decrease methadone blood level. If there's a problem, we switch to levofinol. Respiratory depression is rare in chronic pain patients. It's preceded by sedation. And sedation is easy to recognize and manage and reduce the methadone as needed. What is chronic pain? Chronic pain is persistent pain for weeks, months, or years, present at least 12 hours daily, with an intensity of at least 5 on a 0 to 10 scale, where 0 is no pain and 10 is the worst imaginable pain. 5 is about where a pain wants, you feel like you need something to relieve it. Types of pain: skeletal-muscular and visceral pain, nociceptive pain. We don't use that word clinically much. And neuropathic pain. There is a third type, or complex pain, or mixed pain, which has elements of skeletal, muscular, visceral, and neuropathic pain, which often occurs in cancer and in traumatic injuries. Among all the opioids used to treat severe chronic pain, especially neuropathic pain, methadone has been singled out, apparently because of its use in addiction therapy, and measures are being taken to make it more difficult to prescribe methadone to help patients with chronic pain who have no personal history or family history of substance abuse. Methadone has become the opioid prescribed to relieve intractable pain when all else fails. In treating pain with opioids, we use the World Health Organization 3-step analgesic ladder. The step 1s are acetaminophen and aspirin, no longer the nonsteroidals. The step 2 are codeine, tramadol, hydrocodone with acetaminophen, and oxycodone with acetamin. The step 3, strong opioids: morphine, hydromorphone, oxycodone, fentanyl, methadone, and levofinol. In prescribing opioids for chronic pain, these are the general principles. You use the World Health Organization pain ladder to select a short-acting analgesic. You prescribe it around the clock. Every 3 to 4 hours if this is chronic pain, not every 4 to 6 hours, otherwise you're chasing pain and it is harder to control. You assess frequently, you adjust the dose to relieve the pain, you add up total opioid taken every 24 hours when the pain is controlled, and you select a long-acting opioid every 12 hours using a short-acting opioid, hopefully the same one, for breakthrough pain as needed. You use one short and one long-acting if you can, and then you reassess to titrate the dose. Among the short-acting opioids to begin treatment of for breakthrough pain every 3 to 4 hours, the commonly used ones, hydrocodone, acetaminophen, and it's available orally and in liquid form. Oxycodone with acetaminophen or oxycodone oral liquid is available. One can use hydromorphone or Dilaudid. It's available as oral tablets, liquids, intravenously, and suppositories. And of course, morphine orally, tablets, oral concentrate, rectal suppositories. The oral concentrate is most useful at end of life, given buccally or sublingually 5 to 10 milligrams every 2 to 4 hours as needed. The long-acting opioids are well known. Sustained release morphine, MS-Contin is the most widely used. Avenza and Cadian are other commercially available. Oxycodone, sustained release, OxyContin, also its relative oxymorphone or Opana, and then the fentanyl transdermal patch every 72 hours, Duragesic. Including in long-acting opioid preparations, methadone every 6 to 12 hours, and levofinol every 6 to 8 hours. How does one convert from one or more opioids to another opioid? Step 1, add up each of the opioids currently prescribed in the previous 24 hours. Step 2, convert all the opioids to oral morphine in 24 hours using the equianalgesic tables, which are on slides provided after this lecture. This total is the oral morphine equivalent in 24 hours. Step 3, you choose a new opioid and convert the oral morphine equivalent in 24 hours to the new opioid using the tables to calculate that 24-hour oral dose of the new opioid. Step 4, then you dose that opioid appropriately. At the conclusion of this lecture, the equianalgesic tables available to convert from one opioid to the other. Now, in conclusion, I leave you with these thoughts. An empathic physician recognizing the suffering of a seriously ill patient with severe, intractable chronic pain, not responsive to all measures, should be emboldened to refer that patient to the care of a palliative or a pain medicine specialist, or better yet, become familiar with and comfortable with the judicious prescribing of methadone to relieve the suffering. Once you brush aside the myths, exaggerations, and hype in the opioid marketplace, you will be surprised how well methadone relieves complex chronic pain. With 14 years' experience as a palliative physician, treating nearly 400 patients with chronic neuropathic or complex chronic pain with methadone, I've found that half received excellent relief, 1/4 had fast, satisfactory relief, and the remainder either did not respond or had nausea or drowsiness side effects. Naloxone was used on 2 occasions, once due to caregiver error, once due to patient error. No opioid deaths occur and no hospitalizations were necessary. Thank you.